Ladies and gentlemen, welcome to the future. My name is Zach Gardner, the chief architect at Keyhole Software, and I set out on a little bit of a journey, a little bit of a sojourn, maybe a gallivant is a good word for it. About 5, 6, 7 months ago, I decided that I needed to learn a bit more about generative AI. It was still relatively young. This is a technology that is still in infancy. And I really wanted to find people that had been thinking about it for much longer than I have. As you all know, a little bit of a skeptic, at times a Luddite, but I really felt that it would behoove me, as well as Keyhole Software in general, to have a very well-rounded, very well-oriented, a well-educated perspective on this particular topic. So I did what anyone would do. I went across the four corners of the World Wide Web. I scoured the internet, and I happened to find a lot of people also based in Kansas City that were thinking about this exact same problem. Today with me on the program, I have Chuck Schneider, who's the founder and CEO at Redpoint Summit. I got that right?
Yep, that's correct.
Awesome. So before we begin, my lovely disclaimer. The views and opinions expressed in this program, the views and opinions of the participants, do not reflect their employers, any trade organizations they're affiliated with, any loyalty cards that they have to any grocery stores. This is just two guys. We're just having a chat. This is the fun time. That's all. So to get us started off with, for those that don't know you well, maybe give us a little bit about your background. Where did you work at prior to Redpoint Summit? How did you get into technology? And maybe bonus points, how many patents do you have to your name? Because it's more than me.
Yeah, sure. So Chuck Schneider, my story. I'm a software engineer by background, wrote a lot of code and back in the day. And I started my career at Cerner, so obviously the large electronic health record company, and I was one of the original 20 architects that built the electronic health record. So started back in 1996, and just fun fact, we were on a secret Microsoft project called the Chicago Project, which later became Windows 95. So to date myself a little bit. So it was leading edge. It had like an interface and a mouse, and it was pretty cool. So stayed there, worked for 26 years, did a ton of things there. Really focused in on the medication process and ordering, and did lots of things over the 26 years there. Was an executive for about half the time. And decided to leave and start my own company here a few years ago. So bonus points, don't want to forget that. So yeah. I do have 11 patents, all in the electronic healthcare record space, and those range from how to place taper orders, which is like a tapering dose, to sliding scales, and a lot of it is the complexities around calculating doses and schedules and the different types of complex orders and meds.
Mm-hmm. Yeah, I have a fair amount of experience in that realm, but we'll save that for another podcast. So give me the rundown on Redpoint Summit. What's the business problem that you all are looking to solve? How are you improving your customers' lives through the work that you do?
Yeah, so maybe I'll kind of start with kind of what we want to do is we want to make things efficient. So when we say that in the healthcare space, you can leverage technology to make things more efficient, but you need people and process as well to make that happen. And kind of the origin story, really took place a decade ago or so. And I was at a hospital, and we were going live with a large software install, and a physician was very frustrated at the system. I won't repeat what he said. I happened to be standing there, and he directed that rage towards me, and he took his mouse and threw it at me. He was so upset. So luckily, it was in the age of before wireless mice. So it went about 18 inches and then fell to the desk, and then he stormed off. As funny as that story is, it did leave an impression of software can either improve people's lives or it can drive them crazy. And so really from that point forward, I wanted to make sure it was a mission in my life of how do you help people? And the way I can best do that is through software and through good design and making things as efficient as possible. So fast forward to when I started Redpoint Summit, that is really kind of what our focus is how do we go do the best kind of goodness possible. And the way we do it is through data analytics. And we use data analytics, but make sure that it's analytics with action. So we don't want to generate just another report. Everybody has plenty of reports to go off of. It's how can we actually improve the workflow, remove either cognitive load or hours in a process to have people be more efficient.
Very cool. I've actually heard it said, I think it's in maybe chapter 7 of the book of Revelations, that one of the sign of the end times is that an MD will actually enjoy the EMR that they're using, so
Well,
if,
that is probably a different podcast, but I will be speaking here in the not too distant future on the history of the EHR and why they're so terrible.
Interesting. I mean, when I think about some of the fundamental differences in what we do in healthcare IT, I mean, you think about social networks, like Twitter or X, whatever they call it these days, Facebook, Instagram, they're all designed to maximize the amount of time that an end user spends on that particular platform. They look at things like click-through rates, they look at things like bounce rates and engagement rates, to where their fundamental design, like their ACT and Gs of their DNA, is all about keeping people on there as long as possible. Whereas in healthcare IT, the sign of a really effective system, a really well done interface, is actually the minimum amount of time that a physician has to spend in there, because they got more important things to do. I
So
don't know about you, but I never met a doctor that went to school that was like, I'm gonna not save lives, I'm gonna use an EMR all day.
Yeah, so it's a terrible fact. So today, most physicians spend 2/3 of their shift behind the keyboard. So, so for every 1 hour of patient time, they're spending 2 hours behind the keyboard, documenting, writing orders, looking up, lab results, things like that. And so obviously that generates a lot of burnout. And the best definition that I've ever heard of burnout was from an ED physician, and she said, it's the barriers that are in place to prevent the care that I want to give. And the EHR is one of those major barriers.
Mhm. I mean, one of the common themes that keeps coming up over and over and over when I talk to people in this field is clinician burnout. I mean, PJ time has a non-trivial amount of cost that we're just burdening our healthcare providers with, when they would love to do anything other than that. So I'm curious, when it comes to clinician burnout, what are some of the ways that you're seeing or have heard of generative AI working in that space? Because a lot of what you talked about is content generation. The MD has to document the visit. They have to give them a summary. They have to look at the discharge. Like, is there anything that you've heard of recently in terms of just really compelling use cases for generative AI to help solve this just critical and endemic problem?
Yeah, absolutely. I mean, there's quite a few examples. And so kind of the high level of the way we approach things is, you have to, well, first let's set the context. If you have, it's either a provider or a radiologist or a nurse, they're short on staff, they have a mountain of work to do, they're overwhelmed, and it's like a conveyor belt. The next case, the next patient is coming in. And so how can technology, generative AI, whatnot, any kind of intelligence help with this? And so a lot of this, how do you want to identify those bottlenecks, and then how do you help reduce some of that cognitive load of the user? So a few use cases that we've seen. So physician documentation is an area that takes a lot of time. And again, that's basically you have to write down everything that you've seen, everything you've assessed, and then your plan of action. So now there's ambient listening to the physician talking with the patient, and then it goes and generates that note. The other is really kind of radiology. So physician orders a procedure, and there's an image that's taken in radiology. Going and doing that diagnosis, the radiologist is only so good. I can't remember what the percentage rate is of identifying, say, whether, they identify cancer or not. And so using AI in that space, they can go through those images and then be very accurate and much faster than humans of identifying potential problem areas of a diagnosis. The way we do things is we kind of split into two parts. So we go through like the EHR, just for example, and use pattern recognition of what do users do over and over again at the individual level. And then once we identify those patterns, and we use automation to go basically streamline those behaviors. There's all kinds of tuning that you can do that usually is never set. And so that's another way of just give me the shortcuts, kind of the life hacks of the EHR and spoon feed them to me.
Very cool. I mean, I had definitely heard about ambient listening in terms of just every single conversation I've had. And for the laity, I mean, the way I would think of ambient listening is imagine you're in an OR theater. The surgeon is constantly having to dictate to the team, I need this. This is what I'm seeing. And humans, just by our very nature, like we're auditory. We process sounds and words and ideas and thoughts really well. And being able to get everyone on the same team, having that constant stream of just, of words that are coming out, you should be able to just capture that as it's going and be able to write a summary afterwards. Otherwise, the physician's going to have to spend the time doing that. So it's
Yeah.
a no-brainer,
Yeah, so imagine it's an hour to 3 hour long surgery, and you're right, as the surgeon goes and is stating all this, afterwards, he now needs to remember that 2 or 3 hour procedure and then go write these extensive notes. And by the way, he's got another surgery lined up right after that, and another one and another one. So either you try to squeeze it in, between surgeries, or you try to do it all at the end of the day. And I think people can relate. If you've had 8 or 10 back-to-back meetings and then try to go write meeting notes at the end of the day, you don't even remember what half the meetings are. So definitely the ambient listening, it generates, obviously the physician needs to review, but tweaking things versus writing from a blank canvas, there's been a lot of great feedback in that space.
Mm-hmm. And most surgeries, or at least a lot of hospitals have switched to having at least elective surgeries happen in the morning, because physicians, I mean, they're like anyone else. You wake up, your battery is charged, and every decision you have to make throughout the day, the battery just goes down, 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 down. So
Right.
they've found that the efficacy of surgeries goes up, the potential for, accidents to occur goes down the fresher that the physician is. So as a patient, we also usually have to fast. And I mean, I don't know about you, but like when 9 o'clock rolls around, like 9:30, if I haven't eaten yet, like I get a little bit angry. So it's even, I think, as a patient, in our own best interest to figure out how can we make sure that these physicians are able to go surgery to surgery to surgery and not have sort of sandwiched between there, some fun time sitting down with their little QWERTY keyboard.
Yeah,
The
absolutely. And even the family practice, physician, you take your kid there because they have a sore throat. That physician, if they stayed up till midnight last night and the night before and the night before doing pajama time, as you mentioned, times how many months or years they've done that, their alertness is going to deteriorate after a while. They're just fatigued. We're all humans. Any way we can reduce that work burden, whether it's a physician or a nurse, it definitely results in better outcomes for the patients.
Mhm. And even getting inside of an EMR, the most relevant insights about a patient. One of the EMRs that I've used in the past, it was primarily ambulatory. So primary care providers would use it for those that, aren't, for those that don't know the difference between ambulatory and acute. And it would take usually 3 or 4 or 5 clicks, and you have to know where to go to see if a patient is pregnant, which a patient being pregnant is a whole different course of actions than if a patient is not pregnant. So you would think that it would be designed to show that like front and center, like 34 weeks gestational age. And physicians will often have to find sort of ways around this. And the worst feeling for me, I don't know about you, just like coming from a software background, but the worst for me is when I see someone, when I go to the doctor's office, I always kind of look at like what the nurses are doing just to see, like how they're clicking around the
Yeah,
software. I'll ask them to, like,
yeah.
do you like that? And a lot of times the worst feeling for me is when I tell them, you know, if you told them to do something in this specific way, you can actually make your life better. And they're like, I didn't know that. They didn't go to school. They aren't imbibed with a sense of how things could be from a technical standpoint and how much better their lives could be. So we have to be advocates a lot of times for our end users because that's not their frame of reference, nor honestly, nor should it be.
Absolutely. I mean, the software is complex. I mean, we all use, lots of big software, and we rarely always use all the features. And so
Mhm.
again, the clinicians, that they're under a lot of pressure. I mean, literally lives are at stake and they're busy. They don't have time to go explore the software and become experts.
Mhm.
So that's some of our mantras. How do we go, find some of those shortcuts or hacks and then push it to the user, rather than, doing the 6 clicks to get to here. Like, did you know you can just move that and have that front and center in that certain situation?
Mhm. Yeah, the going back to the other example that you mentioned for sorry, radiology. Um, I heard one MD that I was talking to recently actually say that depending upon the forcefulness, I think is the word that he used of the recommendation, you get a X-ray and then the AI maybe points out something for a physician, that can sometimes be a little bit jarring. Maybe they're looking at the image, kind of studying it, like kind of pondering with their glasses. And then all of a sudden this big thing pops up. And it's like, oh, you need to look at this. For anyone else, I think we would understand there's a fair amount of context switching that would have to take place. So I'm curious if you've seen or heard or have any experience in, maybe some of the forcefulness or some of the more effective ways that it can give recommendations to guide people through it without being so, push notification, so forceful.
Yeah, absolutely. So yeah, the kind of as you described it, there's a term for that called alert fatigue.
Mm,
And so physicians, nurses, they keep getting these pop-ups, and some of them are really annoying. So some that I've seen is, you may be taking care of a 5-year-old kid and you're prescribing them acetaminophen,
mhm,
and you get a warning that says, do not take alcohol with this drug. It's like, I don't think that 5-year-old and that physician need that warning. And so you can kind of understand, in an abstract place where that would maybe be, feasible. But in the real world, there's, a huge percentage of alerts are just noise. And so really the human condition, a lot of these clinicians is, they have to make the decision. Do you ignore the alerts, or do you actually stop and pause and take action? And so the in your face type of alert should really be reserved only for, very important. If you're ready to prescribe penicillin and the patient's allergic to penicillin, that should probably be a stop in your tracks type of thing. But majority of those types of, intelligence that are we're trying to expose to end users, they should really be presented as possibilities, and in a more passive manner. And it may progress as you get further down kind of the decision tree or in the workflow. And honestly, I think, one of the negatives, or potential negatives of AI, is when AI tries to remove all human decision and then presents things as answers rather than possibilities. So, this is what needs to be done, and here's the 6 steps of action versus, I'm detecting this, you may want to investigate, and here's the 3 data points that support why I have detected this. Please verify, proceed as you wish. Those are 2 different kind of cultures and approaches. And so removing cognitive load, but again, posing things as possibilities rather than answers.
I couldn't have scripted a better wrap up myself. I appreciate that as a host. So, if people want to learn more about you, learn more about your company, more about your work, where should they go? Which social networks are you on? Do you still have a MySpace? Do you have a Zanga? I don't know if I don't know if it's around anymore.
The answer is no and no.
Okay,
So I'm,
good.
I'm pretty hip. So LinkedIn is what I call my social media. So you can find us at Redpoint Summit on LinkedIn or Chuck Schneider. And then obviously we have a website, redpointsummit.com, and would love to talk to anyone more about generative AI or just identifying, efficiencies in healthcare. That's what our passion is.
I dig it. Well, keep up the good work. Make sure that we're saving the health system money. And ladies and gentlemen, I hope you've enjoyed the conversation. We'll catch you in the future.